So good evening, everyone. Thanks for joining us again for our Sunday supper sessions this week, this month even. We're going to be talking about the wrist, and we've got some excellent speakers to talk to you about that. I'll shortly hand over to Kriti, who's going to do some introductions and explain who we've got talking to you. We've got a couple of members of the BOTA committee who are also on the panel who'll be fielding your questions. So if you think of any questions whilst we're going, if you could please just ask them in the Q&A box, and we'll try and get around to as many as we can. There'll be some feedback going out at the end, which you can all fill in. And just before we start, some quick shameless plugging in some sort of stuff for BOTA. For those of you who are looking for or have just completed fellowships, we've just launched our BOTA Fellowship Finder website, which is an excellent resource for trying to collate all the information out there about fellowships with reviews. It's free to sign up. So if you're interested, if you could please just go to Google Fellowship Finder and have a look and sign up, and you can get some information for those of you who need it on fellowships. And secondly, we've got our virtual Congress coming later this year. Because of COVID, we've decided to move to that for this year. And as soon as we have more information, we'll send it out to you, but we're hoping to do it sometime around the summer. So that's coming soon. Without further ado, I'll hand over to Kriti.
Hello, everyone. So we'll just allow our speaker to start sharing their slide, but we're going to start off today with Miss Jane McEachan. So she's a consultant orthopaedic surgeon at the Fife NHS Trust, specialising in hand, wrist and elbow surgery. She has set up the renowned Fife Virtual Hand Clinic and is actively involved in teaching and training and co-convening the Edinburgh Hand Course and supervising postgraduate hand diploma candidates. She has a particular interest in clinical audit, medico-legal work and carpal tunnel syndrome, and has numerous publications in reputable national and international journals. So we're extremely honoured for her to have given her time up today to be part of our faculty, and she's going to provide an FRCS-focused carpal tunnel decompression talk on the Montgomery era. So I'll hand it over to Ms. McEachan.
Good evening, everybody. It's a real pleasure to be here this evening. I've given myself the remit of speaking to you about carpal tunnel decompression and Montgomery. Our duty as doctors under the Montgomery ruling is to ensure that we are able to demonstrate that we have shared information with our patients regarding these 4 questions. And we'll assume for the purposes of this talk that all patients presenting tonight have had a trial of conservative management with splints. And I know that you've all just done a teaching session on carpal tunnel, which should have you up to speed. What happens if I do nothing is perhaps one of the least covered questions, since doctors often assume that patients want something done. Does carpal tunnel syndrome spiral out of control and produce nerve palsy, or can it get better? What options are available? Well, for carpal tunnel syndrome, there are basically 2 options available: steroid injection or decompression. What are the risks of these options? And is there a strong recommendation based on available evidence? This is the Fife Hand Clinic website, where we post all our patient information, which you can peruse at your leisure over the next few days. On this page, we give out to patients some steroid injection, outlining what to expect and the potential complications of steroid injection. And in clinic, we use our web page open next to us to run through with patients so that we don't miss anything out. And if we're seeing them virtually, we send out the information by post and ask them to read through the web page before they come to clinic, if they're thinking of having an injection. If we're giving the option of surgery, then we direct patients to our information sheet on having an operation. And this is usually done before the patient makes a decision to have the operation. The risks outlined are generic and not specific to the operation of carpal tunnel decompression. Now, all operations involve interfering with normal structure of the body, whether that involves just the skin or whether it involves soft tissues or bones and joints. And there is a consequence to having your transverse carpal ligament divided at decompression surgery. You all recognize here the bony landmarks of the carpal tunnel, the ridge of the trapezium, scaphoid tubercle, hook of hamate and pisiform. But it's only when you see the carpal tunnel from this angle that you appreciate that it is 3 sides bone and 1 side ligament. From this cross-section, you can use common sense to deduce the three functions of the ligament, which are sacrificed when we do a carpal tunnel decompression. The ligament is very thick, and it is the biggest of the extrinsic wrist ligaments, supporting the arch of the carpus. Loss of this ligament, therefore, gives rise to a feeling of instability of the wrist, particularly when loading and extension, for example, when pushing yourself out of a chair. The ligament is synonymously known as the flexor retinaculum, describing its second function as a pulley, allowing the flexor tendons to produce more efficient power. Loss of the carpal ligament, therefore, allows the tendons to ride up and decreases the efficiency of grip. And thirdly, the ligament gives attachment to the thenar and the hypothenar muscles, such that loss of the ligament gives an immediate reduction in ability to pinch grip. As the wound heals and the hand is mobilized immediately, tendons and nerves glide relative to each other and scar tissue is laid down across the roof of the canal. This scar tissue will eventually substitute for the ligament and allows the functions of the ligament to be at least partly restored. And we see this clinically at around 3 months. But by 1 year, very few patients report ongoing issues related to ligament loss. Patients should understand then that there is a price to pay for decompression. One that somebody who's unable to sleep with severe symptoms may be only too happy to pay, but another patient, perhaps one who catastrophizes symptoms, may be deeply unhappy to live with post-operatively. So tonight, we're going to do a celebrity carpal tunnel clinic and hopefully cover the advice that we give to patients based on the outcomes that we've collected for many years here in Fife. So first into our celebrity clinic is Kylie, a middle-aged woman with an 18-month history of increasingly intrusive symptoms despite conservative management and grade 3 changes on nerve conduction studies. Is it reasonable to sit tight? Yes, we can reassure Kylie that it's quite safe to wait and see what happens. Since we expect symptom intrusion in patients of this age to mirror severity of disease or condition, we can advise Kylie that if her symptoms deteriorate or if she develops longer periods of numbness, then she can always change her mind. In terms of options, steroid injection is likely to improve symptoms, but carpal tunnel decompression is the option associated with the highest satisfaction rate at 1 year, and this therefore is our strong recommendation for Kylie. With carpal tunnel decompression, we see an 18-point improvement in the quick dash and a net promoter score overall of 68. The net promoter score is based on the friends and family test introduced by David Cameron back in 2012. Patients who score 9 or 10 on a linear scale are deemed promoters, with those who score 7 to 8.9 deemed as passives. Anybody scoring under 70 is considered a detractor, and the percentage of promoters minus the percentage of detractors gives the net promotion score. A score of 50 is highly regarded in industry, and here we see how carpal tunnel decompression compares to other common orthopaedic operations and other highly regarded products such as the iPhone and Airbnb. Marcus Rashford is our second celebrity of the evening. At 23, he has a 6-month history of some relief using night symptoms, using night splints and only borderline changes on nerve conduction studies. Is it safe to do nothing? Well, carpal tunnel syndrome in this age group is very unusual and therefore may merit further investigation. In the absence of an association with a chronic disease such as juvenile rheumatoid or amyloidosis, an ultrasound scan may reveal a structural anomaly such as a persistent median artery or a reverse palmaris tendon. Once comorbidity is excluded, is it now safe to do nothing? Well, very safe. There is no real risk whatsoever in waiting 6 months, a year or more to see what happens. Steroid injection is another good option if symptoms are very intrusive. This can give good relief and potentially allow resolution of the condition in patients of this age. There are risks, however, and recurrence is common. Carpal tunnel decompression is an option also, but not a particularly good one in this age group. There is much debate about the role of nerve conduction studies in the management of a carpal tunnel syndrome. Our local data shows a poorer response to carpal tunnel decompression in patients with normal nerve conduction studies, and all our patients in this study had a test injection prior to decompression. Our strong recommendation to Marcus, therefore, is that the risk of doing nothing doing nothing carries no risk, and if he feels his symptoms merit it, then steroid injection is indicated. So next into our clinic is Dame Maggie Smith, and at 86 years old, she can be classified as super elderly. She has a short history with clinically altered sensation and weakness, but no abductor pollicis brevis atrophy. In Fife, we skipped nerve conduction studies in this age group. With these findings, super elderly patients rarely see their GP for no good reason, and we try and accommodate these patients urgently. So can we do nothing? Well, doing nothing is always an option. In this case, however, with a short history and significant loss of nerve function, there is a risk of further deterioration with permanent loss. Had Dame Maggie presented with a history going back a year and no median function, then doing nothing is probably the right option, as there should always be a potential benefit or a clear benefit when surgery is offered. Steroid injection remains an option, but I always worry about the harm that steroid can do to elderly tissue in the carpal tunnel. Carpal tunnel decompression gives, if I could get back onto my, carpal tunnel decompression gives an improvement in Q dash similar to that seen in younger patients, and therefore that would be our strong recommendation. On a cautionary note, many patients at this age have established tri-scaphoid osteoarthritis with carpal malalignment as a consequence. And although we don't have the numbers to write about this, anecdotally, we see an increase in wrist pain and deterioration in radiological appearances of the wrist following carpal tunnel decompression. This could be down to natural history, but I think the extrinsic carpal ligament may play a more important role in maintaining stability in these patients than we appreciate. We've also looked at EQ5D, but comorbidity in patients of this age overshadows any improvement in hand function, and EQ5D usually reflects this at 1 year. Our next celebrity is Tom Hanks, who is a type 2 diabetic. He has a 2-year history and grade 4 changes on nerve conduction studies. Diabetic patients can be tricky. Hand function deteriorates with age and poor glycemic control. Diabetic neuropathy may be present, but even so, the classical history of carpal tunnel syndrome usually makes the diagnosis fairly reliable. Doing nothing is not a good option. Traditionally, surgeons would avoid operating on diabetic hands as the outcome was thought to be poor, and glycosylation of collagen increases the cross-linkages, altering the behavior of the collagen, and this produces thick, soft tissues in the hand. Diabetic patients have an increased risk, therefore, of trigger finger, Dupuytren's, and diabetic chiroarthropathy, all of which adversely affect hand function. In our data, diabetic patients have worse pre-op function and worse post-op function, but the Q dash improvement at 1 year is similar to the cohort as a whole. So we therefore have no hesitation in recommending decompression in these patients. Next up in our celebrity clinic is Bob the Builder. Bob has a unique set of challenges. He has used handheld vibrating tools for many years and has another diagnosis of hand-arm vibration syndrome coincidentally. The symptoms are worse when he is at work, and he has grade 2 changes on nerve conduction studies. He is not at all keen to do nothing as he is struggling to do his job. In addition, he's aware that he can put a claim in if he has carpal tunnel decompression, since it's listed as an industrial disease when related to vibration or heavy repetitive wrist movement. Steroid injection may be a good option for Bob and would certainly be useful in assessing how much of his symptomatology can be attributed to carpal tunnel syndrome. Bob is the type of patient, however, who will struggle with loss of his transverse carpal ligament and the resultant grip strength reduction and instability. It's important to discuss with Bob the potential impact of carpal tunnel decompression on his work and the potential modifications to his work that he may need to make. Patients with a self-reported occupational exposure to vibration have a higher Q- preoperatively and at 1 year, with a poorer mean improvement in Q- score compared to the cohort as a whole. In our database also, manual workers are less likely to return to work than other workers and more likely to report higher disability. Despite the numbers, claims for carpal tunnel syndrome are decreasing. This is the graph from the Department of Work and Pensions with a decreasing trend in red. In Scotland, the rate of the incidence of carpal tunnel decompression operations is steadily increasing and has doubled over the last 20 years. So last into our clinic tonight is Robert Downey Jr., who, like his character, has made a comeback with his carpal tunnel syndrome, and nerve conduction studies show grade 3 change. Recurrent carpal tunnel syndrome accounts for less than 1% of our carpal tunnel workload in Fife. Clinical assessment is important here because it is unusual and it should be differentiated from residual carpal tunnel syndrome, which can be seen if the initial decompression is incomplete. True recurrence usually occurs some years after initial decompression, but behaves in a very similar way with a good response to revision surgery, which we do in the same way using Wallant. So in summary, recommendation for carpal tunnel decompression should be tailored to the individual and include evidence-based recommendations where possible. Thank you.
That's fantastic. Thanks, Jane. Really great clinic you had there. Surgeon to the stars. There's a few questions. Some of it you would have covered, but maybe just sort of your thoughts. One of them is related to steroid injections and one is related to nerve conduction studies. So someone asks, what is your classic patient for a steroid injection? When would you not use a steroid injection, and how many would you give as a maximum?
So, all sort of difficult and tricky questions. In patients where there is a clear, strong recommendation for decompression, patients with grade 3, 4, 5 findings on nerve conduction studies, we know they do better at 1 year than with steroid injections. And we tend to recommend steroid injections for people who have severely intrusive symptoms, but you know, grade 1 or 2 change. And we tend to recommend it as a test injection to assess response in a hand that has other problems going on as well, or maybe a double crush or some other nerve problem. In terms of how many should be given, well, you know, steroid is inherently bad for soft tissues, and although usually we don't see many problems, you can, if you go into a wrist that's had a steroid injection, you can see steroid sitting in the carpal tunnel, and that can't really, multiple steroid injections over the course of a short term can't really be good for people. But then again, we do have a cohort of patients who come back every year or two requesting a further injection, and cannot take time off work or whatever, and just want some temporary relief. I'm not sure if that covers everything that was asked there.
It does. Yeah, I know I use it for sort of diagnostic a lot of the time, as you say. Another question which relates to nerve conduction studies. So some units, people all get a nerve conduction study, even if it's barn door, and others they don't. And I guess what people want to know, and it's never easy, when they're in the FRCS and they're asked, do you get nerve conduction studies? What would your model answer be?
So a nerve conduction study is not mandatory in the diagnosis of carpal tunnel syndrome, and you should be able to predict which patients will do well with decompression from clinical history and examination findings. There are, in cases, such as patients who have vibration exposure, such as young patients, under 38 group, we've got four such patients in our database with complete data set. Where there's something unusual about the presentation, then I think you should get a nerve conduction study. And obviously, nerve conduction studies are not necessarily available as they are in Fife. Our setup in Fife is based on the fact that we have a 2-week turnaround and a neurophysiologist who reports the study, and we cost it at £30 per patient, which is nothing. It's cheap. In other centres, there is no easily accessible service, and you have to work with what local arrangements are available. So in the system that I run, we rely on our nerve conduction studies as part of the pathway, and it's a virtual pathway we have. But I don't, that's so controversial. I don't particularly want to cause any major issues by going into the Fife pathway, but it works. And I think of note is that, whenever you publish a paper on carpal tunnel syndrome, I think it's actually quite difficult to, to assess these things if you don't have a good neurophysiological background for presenting evidence.
Yeah. And I guess another question, just related, the last question, Jane, thank you for answering these, is when you're seeing a patient in clinic, very often, as a trainee or as an orthopaedic surgeon, it's very easy when someone describes hand symptoms, i.e. sensory symptoms, to kind of jump on the carpal tunnel diagnosis. And equally, it's sometimes difficult to fish between those patients who are very specific, i.e. I've got radial 3.5 digits, or many patients who say all of my fingers are numb. So how do you, when you're in the clinic room, kind of break down where it's coming from, i.e. excluding the other more proximal symptoms, pronator syndrome, or kind of disc disease with bilateral?
Well, interestingly, the first 2 sentences uttered by the patient often tell you everything. So a patient with carpal tunnel syndrome will report whole hand numbness, or radial, most of the hand numbness. And a patient who initially reports pain rather than numbness is more likely to have a proximal compression. And a patient who reports index and thumb, that, with pain, that localizes to C6 for me. Patient who primarily points to their middle finger localizes to C7. So whole hand localization is median, and patients with C8 or ulnar-sided ulnar problems will run their hand down the side of their hand. So numbness rather than pain points to carpal tunnel syndrome or cubital tunnel syndrome, and the distribution of the numbness actually tells you very quickly where it's coming from. But obviously there's a routine examination, including neck, upper limbs, and hands, that you just routinely do for all nerve compressions.
Yeah. Fantastic. Thank you very much for that. Wonderful. So I'll pass back to, I've forgotten it, Kriti or George. Someone will follow and they will introduce our next speaker. Thank you.
Okay, that was great. Thank you very much. So now we've got Prof Dias. So Prof Joseph Dias is a consultant and professor in hand surgery, and he's the head of the academic team of musculoskeletal surgery at the University of Leicester. He has a special interest in epidemiology of hand and wrist disorders, as well as education, having been the head of School of Surgery for the East Midlands, as well as the lead for the Orthopaedic research team. He has many international and national publications and has authored multiple national reports and pathways. He was the editor-in-chief of the Journal of Hand Surgery, the president of the BSSH in 2008, and the BOA in 2012. This is only a snapshot of his many accomplishments, and we're truly honoured to have him in this month's faculty for Sunday Supper. He's going to provide us with a focused snapshot on another exam favourite, scaphoid fractures. So I'll hand it over to Prof Dias.
Thanks, and thanks, George, for asking me to contribute to this. I think it's a wonderful thing that you guys are doing. Now, I've been asked to cover scaphoid fractures, and all of you will have come across these. Oops. Right. So what I intend to do is to look at 6 decisions that you need to take about acute scaphoid fractures. Now, this is the commonest carpal injury, a carpal bone fracture, as you know. Many people scratch their heads about this. Now, these are the six treatment points that we have. We go from, is the scaphoid broken? How do you treat it? What do you do when it doesn't join? What do you do when that fails? And finally, how do you salvage the beast? Obviously, I can't cover all this in this time, so I'm going to concentrate mainly on the bottom 2 rungs, or acute scaphoid fractures. The first question that you have is, how big is the problem? How common is it? And in the UK, this works out to around 12 per 100,000 per year. So if you are serving a population of, say, 1 million, then you're expecting to see around 120 acute scaphoid fractures each year. And each of you in your own area can arrive at an expectation of how many scaphoids you will see a year. Now, when you look at this graph, what you can see is that the incidence changes in the different decades, and it is highest in young men right up there. So when you look at the literature, you will see different rates quoted. They're not 12 per 100,000, like the American paper quotes 130 per 100,000, but that is because it was in an army population and all of them belonged in that group. So their reported incidence is exactly the same as we are seeing here in the UK. The second thing is that scaphoid fractures can be anywhere along the scaphoid, but the predominant scaphoid fractures are in the waist of the scaphoid, with only about 1 in 5 in the proximal 20% and even less in the distal 20%. So mostly you're talking about waist scaphoid fractures. So the second question then is, how do you avoid missing a scaphoid fracture? Everyone worries about the litigation risk about missing a scaphoid fracture. The single paper that you actually need to consider reading is Andy Duckworth's paper from Edinburgh, where he used regression analysis to predict whether or not a fracture would be found. And basically his findings were, if you were a young man with a significant injury due to a fall onto the outstretched hand, And when you examine them and you move the wrist into ulnar deviation, they had pain in the anatomical snuff box, then it was quite likely that they had a scaphoid fracture. What do you do to image a scaphoid fracture? We all know that you get 5 views, X-ray views of this, which is a PA, a lateral, a semi-prone, a semi-supine, and then an ulnar deviated view, which is the one shown in this photograph there. But if you cannot see a fracture in spite of clinically suspecting one, then you need to confirm whether or not a fracture exists. And you've got 2 pathways. You can either see the patient after an interval and reassess the patient, particularly if they've got quite significant scaphoid tuberosity tenderness at 1 week. And alternatively, you can image it. And there are 2 alternative imaging modalities that you can use, either an MR scan. The risk of that is that it'll pick up all bone bruises and all other injuries as well. So you could overtreat an injury. Or you do a CT scan, which is much more specific for structure of the bone. So those are the 2. And finally, the most important thing is if you cannot see a fracture, then you need to warn the patient of the possibility of a fracture, because then the patient knows that they've had a significant injury and it could still turn out to be a fracture. However, the relevance of this is quite low, as I'll point out in a minute. So how should scaphoid fractures be treated? Should they be put in a cast or should they be fixed? You can see on the screen at the minute that there are 3 different casts. One where the thumb is left free, the second with the thumb included, but in a position of opposition, and then the third, which is this one, where the thumb is extended. Now, the most defunctioning cast is this one, where the thumb is extended, because now the only grip possible for the patient is a hook grip. They can't do anything with it. This is the freest cast, where the thumb is left free, so the hand can function, and most activities of daily living can be performed in that cast. The alternative to a cast is to fix the scaphoid. So you find the wrist, the thumb crease over there that overlies the scaphotrapezium joint. And this line is on the radial border of the flexor carpi radialis. There's the tuberosity of the scaphoid. There's the proximal pole between the middle and proximal wrist crease. So now that you've located the anatomy, you put your line across the scaphoid, get your Kirschner wire to show you where you are, and introduce it through a very tiny cut just there. And once you're in there and you've confirmed the position, then you just put in a cannulated screw over the top of it. So which is the better way of managing scaphoid fractures? And the paper that you need to read is this one. It's the Swift results, and it's openly available now in the Lancet. So if you put it into Google, you can download it and read it. The summary of the study was that we randomized 219 scaphoid, acute, clear bicortical scaphoid-based fractures to have surgery, and 220 to have a cast. And then we reviewed them at different time points up to 1 year. And we assessed a patient-rated outcome measure, which looked at pain and function. And we found that there was no difference between the 2 groups. The summary of the results of this are here in this infographic. So for all practical purposes, fixing the scaphoid was the same as treating the scaphoid fracture in a cast. Proponents of fixation say that if you fix, then you return to work very quickly. But in fact, we found that the difference between the two groups was only 2 days, a 2-day advantage. There was no advantage with regard to pain and function, and there was very tiny advantage with regard to union. If you fix, then complications occur in 12% compared to 2% if you treat them in a cast, and then only fix the ones that do not join. So this is the summary of the SWIFT study. Complications, you will see the surgical complications obviously are higher in those that have surgery compared to those that have cast. Bear in mind that the ones that were treated in a cast, if they did not join, you did a CT scan and you immediately offered them surgery. Cast problems, therefore, were minor and settled quickly. Reoperation rate was very much higher in the ones that you fixed compared to ones that you treated in a cast. And if you operate, then you do expose the patients to quite serious risks, like this patient who had quite a straightforward waist scaphoid fracture, actually fixed quite well with this antegrade screw. That failed, it was taken out, bone grafted and Kirshner wires put in. That failed, so that got taken out, low-grade infection, chondrolysis, had wound up having an excision of the scaphoid and a four-corner fusion. This is a young man who is going to lead the rest of his life with quite a lot of disability. So, question 4, do displaced scaphoid fractures do worse? So what is a displaced fracture? It is either a gap or a step at the fracture site. And of course, the third way that the fracture can move is that it can angle. So you can get a humpback or torsion. The impact of displacement of over 1 millimeter, either gap or step, is that the relative risk of non-union increases and is 4.4. Now, this is a slide that shows you the 4 classifications of displacement. So you've got with no displacement whatsoever here. And then here it is less than 1 millimeter. You can just about see there's a slight gap over there, but it's less than 1 millimeter. This is 1 to 2 millimeter. And now you can see the step on the radial cortex of the scaphoid, and on the sagittal cut of the CT scan, you can see how it is bent and gapped open at the back, but there's good contact in the front. And this is over 2 millimeters. So the proportions of these are that 3 out of 4 will be either are less than 1 millimeter displacement, 3 out of 4 acute waist scaphoid fractures. 1 in 4, well, about 1 in 5 will have a displacement between 1 millimeter and 2 millimeters, and it's only 1 in 20 that will have a displacement of over 2 millimeters. Now, this is the impact of that classification. So this is if you have 1 millimeter displacement, 2 millimeter displacement, 1 to 2 millimeter displacement, and over 2 millimeter displacement. Firstly, you can see that the numbers decrease quite markedly, with most of them being less than 1 millimeter. Secondly, you can see that only 4% will not join if they are less than 1 millimeter. 15% will not join if they're between 1 and 2 millimeters. So 85% will join, even if you treat these in a cast. And then finally, about half of them will not join if they are over 2 millimeters. So you've got a better discussion to have with regard to the pros and cons of fixation versus the pros and cons of a cast if the displacement is over 2 millimeters. So how should we treat acute scaphoid fractures after Swift? Here is a waist scaphoid fracture. The recommendation is clear that you need to treat it in a below elbow plaster cast, leave the thumb free, return them to function. At about the 4 to 6 week mark, you get an X-ray. And if you are uncertain about the state of union, you can see there's radiolucency on one side and some contact on the ulnar side of the scaphoid. Now, if you are uncertain, then you resolve your uncertainty. You get a CT scan. And if you see some bridging, then this is partial union. So you only need to protect them from heavy activity in the next couple of months and then repeat the CT scan. If, however, you see that there is a clear gap across the waist of the scaphoid at this interval of 6 weeks, then you offer them surgery and go ahead and stabilize them. Now, question 5, has the fracture joined up? And these are the 5 classifications of the state of union. You go from definitely joined, where on X-rays and on CT scans, you actually can't see where the fracture is. Almost fully joined, and you can see in this coronal image that there's a little bit of a defect on the ulnar cortex and a little bit of a defect in the palmar cortex, but this is over 90% bridging, and therefore it's strong enough to take load. Partial union is anything between 70 and 90%. So these are the ones that you want to protect because they're not strong enough to fall. Some of my colleagues, David Ring, Ruby Graywell from Canada, feel that 50% is good enough for most function. So they leave them free, but restrict them from sport. Slight union is less than 20%, but there's some bridging. But when you look at the sagittal cut of the CT, the bridging is very, very slender. So that you are anxious about, and if it's persistent, then you might consider that you need to bone graft and stabilize that, even though there's some tenuous bridging. And finally, of course, when there's 100% loss of bridging or no bridging whatsoever, that is a non-union. So this is what we found in Swift. The union state changes between 6 weeks, 12 weeks, and 52 weeks. And at 52 weeks, there was essentially no particular difference between the two groups. We didn't know whether this was a Hawthorne effect because the rate of non-union, both after surgery, so it's 1 in 200 that had a non-union after surgery, and only 1.8% or 1 in 50 that had non-union after plaster cast. Both those rates are very, very low because in common practice, if you treat them in a plaster cast alone, then you're anticipating around 10% non-union rate. The last thing is, why is all this so important? You know, just because there's a fracture, do you need to do something about it? Why doesn't it just heal like a rib fracture or a clavicle fracture? It is important because if the fracture does not join, there's abnormal mobility between this part of the carpal row and this part of the carpal row. So the distal part of the scaphoid flexes forwards, and there's abnormal loading in the radiocarpal joint, and you start getting arthritis there between the radial styloid and distal to the scaphoid. It's called a SNAC1, scaphoid non-union advanced collapse. And then, of course, it'll go on for you to get some arthritis in the mid-carpal joint, that is SNAC2. And if it involves the capitolunate joint, then that is SNAC 3. Now, the important thing about this is almost everyone will go on and develop arthritis. All the literature up to now suggests that this happens within 5 years. So it's clear that if you're starting off with a young person in their mid-20s, then they will have an arthritic wrist with an, if they do have a non-union, they will have an arthritic wrist within 5 years. So by the time they're 30 or mid-30s, they've got an arthritic wrist, and then they've got to lead their lives with an arthritic wrist. So it's really important to avoid that, and it's a completely avoidable scenario. So even in an asymptomatic non-union, the correct recommendation is to offer surgery. So here's the summary then. We've addressed 6 questions. How big is the problem? 12 out of 100,000. How should you avoid missing a fracture? You ulnar deviate and the patient will complain of pain in the anatomical snuff box. And you can image it with a CT or an MR scan. Should you fix it initially? Very rarely. It's only that definitely or almost definitely over 2 millimeters, but the between the 1 and 2 millimeter step, you should be quite cautious and explain to the patients that 85% of them will join if treated in a cast. Which displacement is important? We've said we classify them as less than 1, 1 to 2, and over 2. And the best way to measure displacement is by using a CT scan. What about union? And the union, there are 3 states. You've got strong enough union for function. You've got partial union where you're a little bit anxious, and then you've got non-union. So you want to classify your state of union into those. And finally, why is it important? Because osteoarthritis is almost inevitable with an ununited scaphoid fracture within 5 years. Thank you.
Thank you very much. And I'll pass it on to George, who I believe is going to be asking you some questions, Prof Dias.
Yes, so we've got a couple of questions on the chat. One here about surgical fixation. So do you always go distal to proximal? And if not, how do you decide whether to go retrograde or antegrade for screw fixation in the waist fractures?
There are 2 ways, of course. So you either go from the front. For most big scaphoids, it's easier to go distal to proximal from the front. But for proximal pole scaphoid fractures, which is the proximal 20%, then you go from the back. And it's, in fact, quite simple to do from the back. There are some clinicians who actually prefer to fix all scaphoid fractures from the back, but it is a little bit fiddly. So for most, if the scaphoid is big, the tuberosity is big, then it's usually no bother, and it's quite simple to do. So for about 4 out of 5, I will go from distal to proximal, and it's only about 1 in 5 or so that I will go from the dorsum from proximal to distal.
Thank you. What about casting? So we've got a question here. Is there any indication for including the thumb in the cast?
There is no proven indication to include the thumb. There is good literature. I've put in the reference in the PowerPoint, which shows that there is little difference between including the thumb and not including the thumb. We also know, and there's good paper. There's a good paper on this, which shows that if you keep the thumb free, then the scaphoid doesn't move much, as long as the wrist is immobilized. So do I include the thumb? Yes, I do, but it's only in hyperlax individuals where I know that because of the ligament laxity that they have, the mobility of the scaphoid is going to be exaggerated. And if I want to counter that, then I will defunction the thumb and accept the disability due to that. But that is the only scenario. So if I've got a patient with Ehlers-Danlos or something like that, then that is the group that I might consider using that.
Great, thank you. And in the interest of time, we'll have one more question. So does smoking have any bearing on your decision to operate, and in particularly with patients who've only got 1 to 2 millimeters of displacement?
I didn't get the second part of the question. The first part of the question, smoking has an impact on all circulation. So it slows down healing. Is there evidence for this? Yes, it is the Oxford study. Peter Burge is the senior author on that, but that is for non-unions. And in non-unions, what Peter Burge demonstrated was a higher number of them failed, or they took longer if patients were moderate smokers. So there is an impact. So what we do is we always advise our patients about the impact of smoking. So they know that we can put a screw in, say, or treat it in a cast, but they are partners in their own care, and therefore they have to improve the environment in which their bone will heal. So it is their responsibility, therefore, to try, if they can, to try and stop smoking. So we always make them partners in this, but we are not judgmental about it because some people can't give up smoking, and if so, they've been warned about the impact.
Great, thank you. So we'll move on now. I'll hand back to Kriti for the next speaker.
Thank you very much, Prof Dias. That was fantastic. And now, last but not least, we have Mr. Heras-Palou, who's going to upload his presentation and share that with you in a second. So he's a consultant in hand and wrist surgery at the world-renowned Pulvertaft Hand Centre in Derby. His areas of particular interest span a great breadth and include scaphoid fractures, non-unions, wrist pain, wrist instability, and problems that occur after distal radius fractures, to name but a few. He co-chairs the Derby Wrist course and is part of the faculty at the AO Hand and Wrist course. He also currently chairs the International Pulvertaft webinars in association with the BSSH and is a keen educator himself. Given his vast experience and expertise in hand and wrist surgery, we are truly honoured to have him as part of our faculty today, and he's going to help us all get to the crux of what is carpal instability. So I'll hand it over to Mr. Heras-Palou.
Thanks, Kriti. Right, we're going to have a quick run, and if you are interested in orthopedics, you'd be interested in mechanics. And I'll put you a mechanics question first, which is that when my kids were little, the little one liked coming on bike rides, but she didn't like pedaling very much. So I got a tag along. So if I connect the tag along to my bicycle, what kind of joint do I need? Because I need a joint that allows to go it up and down for the change of level. And it's got to go right and left as well, but not allow twisting. Otherwise the tag along is going to fall over. Yeah. So a hinge would not do it, and a ball and socket would not do it. Yeah. What you need is something like this, something with a piece that connect two hinges at an angle, and that will give you a fantastic range of movement and will not fall off, and you will be able to transmit forces, transmit torque. And that's what the wrist is. The wrist is two hinges. One is the radiocarpal joint. The other one is the midcarpal joint. Their axes are at an angle. Yeah. So if you have that idea, you understand that there is a segment in between, which is passive. And there is, here is this piece of metal, but in the wrist is the scaphoid, lunate, and tracheatum. And they're passive because they have no tendons attached to them. So they move depending on how the wrist moves. And as Professor Dias just said, if you get a fracture of a scaphoid, for example, or if you get a ligament injury, that segment is not going to work very well. and something bad is going to happen. So the wrist normally moves in a predictable, smooth motion. As you deviate towards radial side, the scaphoid will flex. As you deviate towards the ulnar side, the scaphoid will extend, and that will be nice and stable. But sometimes things happen that make the bone jump. Like you can have this patient, which is very uncommon, but he could demonstrate his own scaphoid instability. If you look at it here, you can see how the scaphoid is jumping and is creating a gap between lunate and scaphoid. And that will cause pain, clicking, swelling, weakness, and the patient will turn up. This is not a patient with scapholunate instability. And what it shows is that if you see here, you can see that the scaphoid subluxates as it extends and it goes clunk and pops in, clunk and pops in here. And that's what happens with the scapholunate instability. There is a little subluxation of the scaphoid that causes a problem. But all this is not new. I mean, Destot wrote this 100 years ago. And if you look at his pictures, he realized the flexion of the scaphoid, extension of the lunate, carpal height is decreased, there is a gap, there is signet ring. It was all there. But people didn't take very much notice of it. And Geoffrey Fisk, who worked just north of London in the 1960s, paid attention to that. And he's one of the first ones that mentioned the key role of the scaphoid to prevent what he called the concertina collapse, carpal instability. And this was picked up by these two surgeons from the Mayo Clinic, Dobbins and Lynchide, and they wrote the seminal paper on wrist instability in 1972. So that's nearly 50 years ago. We've been looking at this. And what they had in those days were radiographs and arthrograms. So they used to run to x-rays and watch the arthrograms as they were done to see where the dye was going, see what ligaments were perforated, and then correlate that with the appearance of the x-rays and make correlations with what ligaments are injured, what appearance has. So from their point of view, instability was a radiographic abnormality. But you know that there are patients that come with radiographs that are normal. This is one of my patients with scapholunate instability. You look at the x-ray, they seem normal. It's only when you get the stress view. That's a radiograph with the patient making a fist, and you can see that the scaphoid flexes, and there is a gap between scaphoid and lunate. This is another patient of mine. He's a farmer in Derbyshire, and he doesn't have a problem. So there are radiographic abnormalities without instability as well. So the first point I wanted to put across is that instability is not the same than a radiographic abnormality. Instability is a dynamic problem. And normally the wrist moves nice and smooth. And what happens is that when a lesion impedes this, then it will not move nice and smooth. And at some point it will correct its position, either by subluxating or by reducing, and that will cause a click or a clunk. So one way to define it is to say that the wrist is unstable when it's not capable of bearing physiological loads without yielding. So the wrist gives way when you're doing things in your activities of daily living or your work. So you go from this predictable smooth motion to somebody who's got a clunk. As this patient here, you can see that as he moves from radial to ulnar deviation, the wrist remains depressed because the whole proximal row is flexed. And then at the end of ulnar deviation, it jumps up with a clunk. Yeah, and that's a similar patient, that operation, dorsal approach to the wrist. You can see the whole of the proximal row jumping just by compressing the wrist. But what about a patient that has ligament laxity, that has a normal movements, and you can elicit a click on examination? But she works in an office, has no sporty hobbies, and has no symptoms. Is this carpal instability? Well, no, this is not something that needs anything doing. So to have clinical carpal instability, which is what we are interested, they have to have mechanical instability and symptoms. We always think of the post-traumatic one, but remember that there are other causes of it. Like this is a rheumatoid patient, and you can see that down the line, radiographs of the wrist show a gap between scaphoid and lunate, ulnar and palmar translation of the carpus. And that's due to ligament damage because of the rheumatoid arthritis. In what direction it moves? Well, it can move in any direction, but the two typical are dizzy and busy. And that comes from that original paper from 1972. They called the blocking in the middle, the lunate, also a scaphoid and tracheatum, the intercalated segment. So they decided that if the lunate was extended, it would be a dorsal intercalated segment instability. If we went towards palmar, they call it the PC, and then that was changed to VISI, volar intercalated segment instability. And then they describe these patterns. If there is a problem within that intercalated segment, so that will be either scapholunate or lunotracheatal, they call it dissociative because there's a dissociation in the proximal row. If it's the whole proximal row that is unstable but as a block, that's a non-dissociative. If the cause of the malalignment is from outside the wrist, and the typical one is after a distal radial fracture, there is a malalignment of the carpus, that's adaptative. And if there are components of dissociative and non-dissociative, for example, in a perilunate dislocation, there'll be a rupture of the scapholunate ligament, for example, but also discontinuity between the proximal row and the middle rows and the distal rows. So that's called complex. And then they developed these acronyms for it. So carpal instability dissociative will either be a scapholunate, which is the common one, lunotracheatal, much more rare, and you are probably familiar with what's called the Terry-Thomas sign, which is that gap between the scaphoid and lunate. So scapholunate instability is the instability between scaphoid and lunate. And you can see this guy that could click his scaphoid. If you ask him to do it with his other hand, he cannot. I think comparing both sides is always helpful. And doing a dynamic investigation, fluoroscopy, is the most helpful in my hands. So this is a cadaveric preparation, and you can see what happens. That's the scaphoid, that's the lunate. The scapholunate ligament has been divided, and as you load the wrist, the scaphoid tends to flex more and the two come apart. And then down the line, the dorsal part of the scaphoid will subluxate dorsally. And what you can do is you can arthroscopy, that's putting a little telescope, 2.7 or 1.9 millimeters, and you have a look at that. So you look at the arthroscopy, that's the scaphoid, that's lunate. In this case, I can put the scope in between them. So that's in the radiocarpal joint, can go between the scaphoid and lunate into the midcarpal joint and see the capitate. Yeah. So in our staging, that would be a stage 4. That means a complete dissociation. But that gives us an idea of the magnitude of the problem. Also, you need to know how to test clinically. And the commonest test is the scaphoid shift or Watson test. And what you do, you move your wrist from ulnar to radial while resisting the flexion of the scaphoid. That's the natural thing. If the ligaments are intact, the scaphoid will push hard against your thumb. But if they're not, the scaphoid still needs to get out of the way, so it will subluxate dorsally. And if you put your index finger on the dorsum of the wrist, feeling the dorsal aspect of the scapholunate joint, you'll feel the scaphoid clicking or subluxating, while the patient may feel pain or clicking or something coming out of place. So this is the Watson test. And what happens when you're doing that, this is doing it under fluoroscopy. See. And you look at it here, the scaphoid rides over the dorsum edge, the edge of the radius, and then clicks back in. So that's what happens when you're doing the Watson test. And this is an extreme case of it. The patient was anesthetized, and if you look at it, the dorsum of the wrist there, you'll see that as putting pressure goes poink there, yeah? It goes pop, and you can even see it. Actually, you shouldn't do that on a patient that way because it's painful, but you can see that the scaphoid actually subluxates dorsally. What about lunotracheatal instability? Well, that's what it is. That's the scaphoid, lunate, that's the tracheatum. And on certain movements, there'll be this abnormal displacement between the lunate and the triquitum there, and that will cause a click that will be painful and makes the grip weak. You can scope it again, and this is looking at the mid-carpal joint there, looking at this area here between the lunate and the triquitum, and I'll put the hook there, and you've seen that classification. I'll see first if I can introduce the hook. Yes, I can, so that's at least a grade 2. And as I push it in, sometimes some rubbish comes out. See what happens, yeah. And then I can turn 90 degrees the hook, yeah. So that's a stage 3. This is how we stage them and diagnose them. What about carpal instability non-dissociative? That's usually mid-carpal joint, but it could also be radiocarpal joint. So mid-carpal joint is this. It's a clunk. This is palmar mid-carpal instability, which is the commonest one. And patients will complain of a clunk. Some of them can show it, can do it themselves. And this is a catch-up clunk. The clunk happens when it's reducing. And what's happening if you screen this, you can see that scaphoid, lunate, and triquitum are flexed. And as you take it towards the ulnar side, the whole proximal row jumps into extension, which is where it should be. So you remain flexed to the end as you go there, and then sort of pop and corrects. So here, scaphoid, lunate, and triquitum move as one piece. So there is no dissociation. It's a carpal instability, non-dissociative. You can also have radiocarpal instability after an injury, like this lady who had a fall in hospital, actually, after she was admitted for an infection. And most commonly is after big trauma. This guy was involved in a car accident, and you can see that this is not quite reduced. The lunate is not sitting on the radius, and will only be reduced if you fix it and repair the ligaments, which is that. Carpal instability adaptive, you could say, well, that's not real instability, just a malalignment, which it is. You're right. It's because this patient has had a distal radial fracture, has healed with dorsal tilt, and the carpus is adapting. And because of that, the thing to do is correct the radius. And there are several ways of correcting it, usually with a distal radial osteotomy. The classic way of doing it is through dorsal approach. You do an osteotomy, correct the volar tilt, correct the radial tilt, put some graft, and then you can put some K wires or a plate. Nowadays, we don't do this very often. We tend to do this through volar side, but this works very well. And you can see that once the radius is correcting, the carpus is well aligned. I'll show you another case, and they do very well. Once the geometry is corrected, that's done. So this lady was treated in plaster with a distal radial fracture that initially looked all right. That doesn't look too bad. But then in plaster collapsed, and she developed a lot of pain. So how we do it now more often is do the osteotomy from a volar approach. So you do an approach between the FCR and the radial artery. And the first thing you do is put the plate on it. And as you put the plate, the limb of the plate will be standing off. Take the plate out, do your osteotomy, put the plate down. And as you push the plate down, that will correct the osteotomy for you. You can put some graft there, and you get the same result from there to there. There is a recent paper by Professor Dias as well that says that the objective when you are reducing distal radial fracture is to align the capitate with the radius, and I think that's a good concept. Then, if there is a dissociative component and a non-dissociative component, that's carpal instability complex, which is the one, and this is your perilunate dislocations. So a wrist is kinetically unstable when it's not capable of bearing physiological loads without yielding. There is a pattern, and I think you need to know that for the exam. And this is a very quick run, but if you want to know more about that, there are several webinars on the Pulvertaft videos channel, which is open to anybody on YouTube. There is one of mine on clinical examination that goes in detail. I think you need to know a bit about that. And if you're going to look at those, the first one I will look at is the wrist anatomy and biomechanics, because if you understand that, it will be very easy. Thank you very much.
Thank you so much. That was amazing, and we've learned a lot, I'm sure. So I'm going to pass it on to Alison, who's got a few questions to finish.
Yes, thank you very much, Mr. Heras-Palou. That was a fantastic talk, shedding a huge amount of light on the somewhat murky topic of carpal instability. A couple of questions we've had through. One of our candidates was wondering, at what point would you consider a wrist arthroscopy in the diagnosis of instability and scaphoid ligament injury, for example?
I don't think the arthroscopy gives you a diagnosis, to be honest. The diagnosis is made by the history and the examination. That's how you diagnose it. They either have instability or they don't have it. Now, the arthroscopy is good to stage it. It tells you where the injury is. It tells you what the joint surfaces are like. It tells you there are any associated problems, and it determines the treatment if you're going to go for a surgical treatment. Yeah. And more or less the same applies to MRI scan. I don't get many MRI scans. It's the patient that tells you what's happening.
Excellent. I'm also being advised that apparently the Mayfield's classification is a favourite topic in the FRCS, and someone was just wondering, do you find that the Mayfield classification is useful?
For those of you that don't know, it is a classification of perilunate injuries, and that's because there is a grading and a range that follow a sort of logical order. I think the Mayfield classification helps you understand the injuries when you see the radiograph and what soft tissue injuries there's going to be. It doesn't determine your treatment. It doesn't affect it very much, and is not applicable to every patient or every pattern, but most of them. This is a very famous paper, Mayfield, Johnson, and Kilcoyne. And what they did is hyperextend cadaveric wrists suddenly and forcefully, and then look at the injuries. What it doesn't say in the paper is that to get the number of perilunate dislocations they got, they had to force hundreds of cadaveric arms. And that's why the study has not been repeated. I don't think it will be allowed now.
Excellent. I think the last question, just to finish up on, one of our attendees was wondering, with scapholunate ligament injuries causing instability, there's a named pattern of arthritis that's fairly predictably results. Are there similar patterns for other forms of instability?
No is the answer. There are patterns for degeneration after scaphoid fractures, which Professor Dias has shown you, and there is a similar but not the same pattern for scapholunate injuries. There isn't the same thing for lunotracheal injuries because it's different. And mid-carpal instability is not one condition, it's a group of conditions. So the pattern of degeneration you get is very variable. There are 5 patterns of degeneration there. So no is the answer.
Brilliant. Right, thank you very much. I think we're pretty much up on time. I'd just like to say thank you very much for 3 excellent talks, and I'll just hand back to Kriti to round things off.
Okay, well, thank you very much for the amazing talks that we've had from all 3 speakers. I think the general feedback we're getting is that people have learned an awful lot and it's been extremely useful. So thank you for giving us your time this evening. I'm going to pass it over to George now, who is just going to tell you all how to give some feedback and also a couple of other things that we just want to let you know about.
Thank you, Kriti. So yes, so if everyone could please fill out their feedback, you'll get an email, a link when you close, and you'll get an email with it as well. And it's really helpful for us to continue to build these sessions and make them better for you. I mentioned at the start, we've got our BOTA Fellowship Finder, which is a new website we've just launched to help with finding a fellowship. So for those of you who've just completed, or for those of you who are looking for information about fellowships, please sign up. It's totally free. And there's lots of information going to be uploaded on there shortly. And also an early announcement this year, our BOTA Congress will be going virtual and hopefully running in summer of this year, or will be running in summer of this year. So keep your eyes on our social media channels for more information. Our next session will be the end of next month on the elbow, and we'll be sending out sign-up links for that very shortly. And for those of you who'd like to watch this session back, the videos will be available on the new BOTA website once that goes live, hopefully at the end of next week. All the sessions can be watched back via there. And that's it. Thank you very much, everyone, for attending.
George, I've put the link to those videos on the chat. If anybody wants it, they can just copy it, which makes it easier.
Perfect, and I'll put that link in the description on the YouTube video as well.
Thank you very much, everybody.
Thanks a lot, everyone.
Thank you. Bye-bye.
Thank you
Good to
very
see
much.
you, Jane. And